Welcome to AETCM, the emergency medicine channel. Sir, today I'll be presenting a case of a 20 years old male with alleged history of collision of scooter onto a billboard, following which he had LOC and 2 episodes of vomiting. He was also complaining of neck pain. On initial assessment, patient was conscious and agitated and was able to complete full sentence. There was no active bleeding site seen. Smell of alcohol was present. At this point of time, cervical collar was applied. A primary survey, airway was patent, no pooling of secretions or gurgling sounds. Breathing, bilaterally equal chest movements, air entry was bilaterally equal, no added sounds. Saturation of 96% on room air and respiratory rate of 24 per minute. Circulation, heart rate of 118 per minute with a BP of 170 millimeters of mercury. At this point of time, 18 gauge IV cannula was inserted. Disability, GCS was E4, V4, M5, and pupils are equal and reactive to light. He was not moving any limbs.
He was not moving any limbs.
He was not
First 10-second assessment, you told patient was agitated.
agitated, as in making sounds.
Sounds, but not moving any.
Not moving.
Upper limb and lower limb.
Not moving upper and lower limb, but was making sounds. And coming to exposure, temperature was 97 degree Fahrenheit with GRBS of 110.
But that's not exposure. In that, you have to say disability. A, B, C, D, right? D. So, not moving on for limbs means at that time you have to tell patient that was assessed for bilateral upper limb and lower limb weakness, and patient not moving limbs but was moving. Like, see, when you say patient is not moving limbs, it can be either due to depressed mentation or inability to understand you or real neurological deficit. So to identify this, you have to make sure the patient obeys your commands. So you can say the patient can move his tongue or obeys commands by moving his tongue or closing his eyes and all, but patient is unable to move his distal extremities. Okay, and if you say that, then the next thing is to check for deep tendon reflexes. So because in ABCD, the disability part, if you say periphery neurological deficit are present, then we are suspecting a spinal trauma. And if you are suspecting spinal trauma, we have to confirm a spinal trauma at that point, not in secondary survey. Okay. If you don't get peripheral neurological deficit, well and fine. You can just say patient moves all 4 limbs. You can go ahead. But if not, then you have to do basic neurological assessment to identify the site of spinal injury.
Here he was GCS was E4, V4, M5. He was not obeying commands. He was just making sounds. And when he coming to the neurological part, he was not moving any limbs, and we checked the tone. It was lost in all limbs. Like hypotonia was there in all limbs, and the deep tendon reflexes were absent. The upper and lower biceps, triceps, supinator, knee jerk angle was all absent, and the plantar reflex was mute.
Okay.
And sensations also we checked. Sensation was intact. Only above initially we couldn't check, but afterwards
only in D
initial
D disability we need to say about deep tendon reflexes, because we are not really concerned about sensations. We are concerned about spinal level identification, not exact spinal level. We are saying, okay, patient may have a lumbar spinal injury or thoracic spinal injury or cervical spinal. That's the whole idea. So patient is able to move upper limbs or not. Patient is able to move upper limbs, okay. Then we are looking at a below cervical injury or above cervical injury. That's the cutoff we are looking for. So if you say patient not moving any limbs, but patient is obeying to commands, moving the tongue or moving the head as per our instructions, then we can say, okay, patient has quadriplegia. So this is quadriplegia. Patient has lost tone in all 4 limbs, not able to move in all 4 limbs, and patient is moving his head by himself. In agitation, he was moving his head by himself.
But we put cervical collar.
Cervical collar, but initially when he came in.
Yeah.
So we are looking at a quadriplegic patient. So we are dealing with a cervical spinal injury.
Injury.
Fine.
Then the pain score was 7 out of 10, and we gave injection PCM 1 gram. IV stat was given, and also for vomiting, injection ondansetron 4 mg IV was given, and since there was smell of alcohol, injection thiamine 500 mg IV was given. And adjuncts of primary survey, we had done ECG was showing normal sinus rhythm with sinus tachycardia was there, with EFAST was negative, and VBG showed HB of around 15.2, pH of 7.42, bicarb 24, lactate 0.8.
Why did you do a VBG for this patient?
To check for any if there is any bleeding, there can be HB drop can be there, and
No,
acidosis.
see, this patient's VBG you are taken in adjuvants to primary survey,
Yeah.
right?
Yeah.
Not in breathing and ventilation, not in circulation and hemorrhage control. If you done there, you could have told respiration and circulation. You are done at adjuvants. That means you have assessed the patient, you have identified the emergency, a point of care, and then you are asking for ABG. Why do you want a blood gas in this patient? What is the only indication to get a blood gas in this patient?
This kind of patients, we can look for cervical injury for any PCO2 build-up.
No, this is the only thing. PCO2 build-up is the only thing you require because you have a quadriplegic patient. Now, quadriplegic patient means you are having a C5 and above spinal cord injury because deltoid supply is C5. So, C5 and above is your spinal cord injury, and your phrenic nerve supply is C5.
C3, C4, C5.
Yes. So, any cord injury above C5, we should look for phrenic nerve involvement. Unfortunately, for us, in acute phase, it will be difficult for us to assess the respiratory effort of the patient or respiratory depth of the patient and all. So, easiest thing is to get a baseline PCO2 level to assess whether PCO2 is building up over time. So, this ABG is basically for reference point. At presentation, what is the patient's ABG? So, it should never be a VBG for this case because you have already done disability. You know it's spinal trauma. So, your ABG is for a reference point of PCO2. You don't have a hypotension. Patient has tachycardia 110 or 113, but no hypotension, no external bleeding points. You have palpated all peripheral pulses, all that are normal. So here there is nothing to suggest hemorrhagic shock, isn't it? There is no desaturation, there is no tachypnea or bradypnea as such. So respiratory component is also not there. So this ABG is basically for reference point. Fine.
Secondary survey. We have a 20 years old male who presented to ER with alleged history of loss of control of his scooter, and he collided onto a billboard, after which he does not remember the events, and but the accident was unwitnessed. He also had 2 episodes of vomiting en route, and also had weakness and numbness of all 4 limbs. And
when did he have the injury actually? When did he have the injury, sustain the injury?
how much hours back?
Yeah.
Around 2 hours back.
2 hours. 2 hours prior to the presentation to ER, right?
And there was no history of any seizures or ENT bleed. He was not allergic to any medications, not on no significant past history, not on any regular medications. On examination, also patient same CNS, GCS was E4, V5, E4, V4, M5 with the pupils equal and reactivity light. Motor examination, bulk was normal, tone was lost in all limbs, power was 0/5 in all limbs. Deep tendon reflexes were absent. Sensory, we checked later, which was sensations were intact above both clavicles, and there was no sensation below the level.
So what do you say that condition is? You are saying patient is having power 0 out of 5 in all 4 limbs. Patient's tone is absent in all 4 limbs. Patient's deep tendon reflexes are absent in all 4 limbs. What is that state called as?
Spinal shock.
It's called as spinal shock. So what is the difference between spinal shock and neurogenic shock?
A neurogenic shock is basically because of the sympathetic activity suppression. So it will
Is
lead
it
to
suppression or
vagal stimulation.
is it
Sympathetic tract
suppressed
is
or
getting
tract is getting disrupted?
disrupted.
So it's not suppression, it's
Disrupted.
loss of sympathetic tone.
Sympathetic.
Loss of sympathetic tone.
So towards the heart, it will cause bradycardia, and towards vasomotor tone, it will cause hypotension.
Hypotension. So
So
bradycardia, hypotension
hypotension will be the
is the classical features of neurogenic
shock.
shock. And what is the difference between neurogenic and spinal shock?
Spinal shock is a state in which the patient initially will be having the complete hypotonia with a reflexia stage initially, and it will then become changing into spasticity,
transient stage, which then will progress to a
UMN
UMN
type of lesion.
Hyperspasticity, hyperreflexia, and plantar upgoing reflexes, right?
Yes.
Fine.
Then bilateral plantar were mute. Then abrasions were seen over the outer aspect of right arm and anterior aspect of left arm. No other significant examination findings. Coming to investigations.
No, this is fine. But here you have a diagnosed cervical cord injury patient, isn't it? So identification of spinal level is important. So here you are telling that above the level of clavicle is when patient can accept the sensory level. So above the level of clavicle is C3, C4 levels, right? C4 level is clavicle, C5 is deltoid. So deltoid patient is not able to appreciate the...
Not able to appreciate.
So C4 and above sensory levels, okay. Patient is not able to abduct his hands.
Not able to
so
move also.
C5 and above is the motor level of the patient. So we are looking at a high cervical injury. That is one part. Now, whenever you get any injury above the level of clavicle, including spinal injury, what other associated injuries should you look for? How is the presentation of injury?
Presentation.
How did the patient sustain these injuries?
Mechanism. That is unwitnessed accident actually.
Okay. But he
And
was
he does
in a
not remember the
motorbike.
event.
He was in a motorbike, right?
Yeah, he
And
was in
he
a scooter
collided with
on the post, a billboard.
Electrical post.
Yeah.
So it's an immovable object, isn't it?
Yes.
So the entire kinetic force of the rider is transmitted to him, isn't it? What other injuries should you look for? If this patient collides with a immovable object, the patient will be ejected from the vehicle, but will be on the line of travel. Patient will always continue to go forward, inertia, right? So patient would have already collided with the post, causing an abrupt termination of movement of his upper limbs and face, causing injury to the spinal cord. Causing hyperextension injury to the spinal cord is one thing we have to expect here. It can cause complete transverse transection of spinal cord. Looks like it because he has got complete quadriplegia. So looks like complete transection, but most probably a hyperreflection. But most importantly, we should look for associated facial bone fractures, maxillary sinus, frontal sinus fractures, any orbital fractures, any anaphtalmosis. Because if patient has maxillary rumpofascial fracture or orbital fractures, there can be anaphtalmosis, right? Patient is conscious, patient is trying to move around. You can check ocular movements to look for any painful ocular movements. If it is there, it can be impingement of ocular muscles into the fractured bone fragments. Second thing, any CSF secretion from oral cavity, nasal cavity, or from external auditory canal is important here, because already patient has sustained C-spine injury. What is preventing it from sustaining intracranial injury and facial injuries. Patient can also have intracranial injuries, any depressed skull fractures, isn't it? You have to look for depressed skull fractures, you have to look for any subcutaneous emphysema in the cranium. It can show that any frontal sinus or mastoid sinus have been fractured. So you can expect pneumocephalus, SDH, EDH, SH, isn't it? So any spinal trauma patient should be concurrently look for facial injuries and intracranial injuries. Okay, isolated spinal cord trauma injury can only be seen in penetrating injuries, gunshot injury, stab injuries.
Whiplash.
Yes, blunt trauma should always be looked for associated injuries. And this patient, we should also look for thoracic cavity injuries because colliding with a immovable object. So, this patient, it's very important to look for other associated pelvic injury, thoracic cavity injury and abdominal injuries because patient sensations are lost. We are looking at transection of spinal cord. That means patient will not complain of tenderness. So you have to do a complete palpation of rib cage to rule out flail chest or rib fractures. We have to look for a extended EFAST to look for pneumothorax. Pericardial injury, pericardial effusion means traumatic pericardial effusion. A ECG to rule out cardiac arrhythmias, which will show cardiac injury as such. Not only fast, a proper ultrasound to look for splenic or liver lacerations. You don't have to develop hemorrhage to have grade 1 or 2 splenic and liver lacerations. Unless you are having active hemorrhage, the patient is not going to lose blood or go into shock. But patient can develop these injuries. In a normal patient, patient will have pain, severe tenderness. In this patient, it is blunted, isn't it? So these things should be looked after in secondary examination. So this patient, any traumatic, high code traumatic patients, the entire body should be palpated, including long bones, because any fractures the patient wouldn't be able to feel. Okay, that is one thing. Second thing, in primary survey itself, we identified this patient is having a spinal cord injury, a possible transection. We have to put a Foley's catheter for this patient because it's already been 2 hours or 3 hours. This patient is prone to develop bladder distension and urinary incontinence. Not incontinence, urinary retention. So, prompt use of Foley's catheterization is very important in this kind of patients. Okay. What else will you look for in these patients? What other features would you look into? On presentation, you are told this much. No, you have done your examination, you have made your plan. So, or else we'll come to your next step. What is your next step? Diagnostic modalities, right? You have made a diagnosis of transection of spinal cord. Now you have to prove its transection. What is the diagnostic modality you have gone for?
MRI, C-spine with whole spine screen.
Yes. Since patient is having quadriplegia or quadriparesis, any neurological deficit is there, it's better to go for a MRI spine rather than a cervical spine. Cervical spine is important because we need CT spine. CT spine is important. We need to look for how the trauma is. How many vertebrae are affected? What is the current location of the fractures? Is it a body fracture or is it any associated fractures are there? So CT spine will be required to assess the fracture and injury site. But to assess the spinal lesion, we need MRI. And as spinal lesion is important, MRI should be given preference more than CT. That's one thing. MRI of
C-spine with the whole spine screening.
Yes, whole spine screening is very important. Any blunt trauma, spinal cord injury, if a patient gets into, we should go for a whole spine screening because since blunt trauma, we wouldn't be able to localize any other lower spinal injuries if already existing higher spinal injuries there. right now you have cervical spinal injury. We can never assess whether thoracic spine is normal or not because it will be masked. So always for any blunt the neurological deficit associated spinal traumas go for whole spine screening. So you went ahead with spinal MRI. What is the reports?
It showed a burst fracture involving C5 vertebral body with retropulsion of posterior segment causing severe compression on this cervical spinal cord. And there is diffusely bright T2 signal at C5 level. Cord suggests cord contusion or edema. Curvilinear hypointent signal within cord at C4 to C5 represents focal hemorrhage. And hyperintense signals involving C5 to C6 interspinous ligament represents focal tear.
So basically at C5, C6 level, patient has sustained significant spinal cord injury. Okay. But C5 is the level and C4 is spared. So phrenic nerve as such is not affected in this patient, isn't it? Okay. So you have got your MRI reports. How do you want to proceed?
For this patient, we had also taken CT, whole spine was, C-spine with whole spine was taken. It showed a C3 and C4 vertebral fracture also,
Okay.
involving right inferior articular process and C5 vertebral body fracture and bilateral lamina fracture
Okay.
with fracture fragments compressing canal, spinal canal. And other X-rays are also taken, chest X-ray, pelvis X-ray. And
All those were normal.
Normal.
No pneumothoraxes, no pelvic injuries as such. Okay. How do you want to proceed now? So your diagnosis of isolated cervical spinal cord injury is proven with MRI. How do you want to proceed? What are the next steps?
First, we have to initially keep him on a cervical collar, and you have to do pain management. And we had started him on steroid, high dose steroid. Methylprednisolone was given.
How much? What is high dose steroid? What is the
bolus 30 mg per kg over 15 minutes, followed by 5.4 mg per kg over 24 hours.
What is this protocol? From where is this protocol? This is acute traumatic spinal cord injury steroid, bolus steroid protocol. From where it is derived? Or is it indicated?
Because he's a quadriplegia.
Understandable. What I asked is, what is the base for this treatment modality? Or is this treatment modality necessary in the current scenario? Or current
Reduces
age?
the edema, cord edema.
No, the idea is to reduce cord edema. The idea is to reduce cord edema and to prevent intracellular potassium loss of the spinal cord, intracellular potassium loss and lipid peroxidation reduction. These are the ideas of high dose methylprednisolone, loading dose of 30 mg per kg and 5.4 mg per kg per hour infusion for
24 hours. 23
hours. This protocol is derived from a study named as NASIC study, National Acute Spinal Cord Injury Study, NASIC 2. NASIC 2 study is the study that came out with this protocol, saying that if you give this for patients within 8 hours of presentation, patient's morbidity, that is motor improvement, can be better. So there is a criteria. So patient should be presented within 8 hours of spinal cord injury with diagnosable neurological deficit. You can start this. But then NASIC 3 study came out. NASIC 3 study showed that after 3 hours of injury, sustaining injury, and within 8 hours is the time duration which to be given. Even then, mortality, there is no improvement. Morbidity, there is mild improvement in motor function, but not real, any prognostication improvements are not there. So, NASIC studies and all came out very long back, like 2005-6, around that time. So, 20 years later, now, is this indicated or not? Currently, there are huge debates whether this is indicated or not, but most of the Western departments have moved away from bolus doses of steroid. The main thing why they have moved away is mainly because it has never proven that patient will improve. The spinal injury will be reversed or a significant spinal cord improvement will be there, which will improve patient's quality of life. So patient may not be some change in spinal cord activity can be there, but not significant enough to improve quality of life was ever proven. But almost all patients, since we are giving very high doses of steroid, started developing sepsis and other complications due to high dose of steroid treatment. Because of that, most of the societies have withdrawn need for, it has become case to case basis or doctor judgment at call. Mainly, even American Academy of Emergency Physicians have also told it's only a mode of treatment, not a guideline for treatment. So it's not really a indicated treatment strategy in the current scenario. There is a possibility if you and the neurosurgeon is on the same page about it, you can give, but not necessary. You don't give it, it's not against the treatment protocol or it's against patient care. Okay. So anyhow, high grade steroid is one thing. Actually, if a patient develops spinal cord injury, what are the modes of treatment that you can offer? It is supportive care and prevention of secondary injury. How can you prevent secondary spinal cord injuries?
Immobilization.
Immobilization, true. So how will you immobilize a spinal cord injury patient? One is hard
So,
collar.
hard collar.
Hard collar. For how long will you keep? Up to 48 hours.
48 hours.
After 48 hours, even hard collar will start causing pressure ulcerations on the posterior occiput. Hard collar otherwise also decreases the cerebral venous outflow. Okay, and most importantly, in emergency room, it is difficult to give oral suctioning for the patient for toileting the oral cavity and removing of phlegm and all, which can eventually cause aspirations. Okay, so up to 48 hours you can keep the patient on a hard collar. What about spinal long back rest or spinal
Immobilization.
spine board? Spine board.
Spine board.
Is it indicated? Not indicated?
While mobilization
While
is spinal cord is
transporting
Only for
shift.
mobilization you should use spine board. It should not be, patient should never be kept on spinal board. There is no mortality or morbidity improvement on keeping a patient on spine board. If you keep a patient on spine board, 2 hours is the only time required for pressure ulcer development on the shoulders, buttocks and the back of head. So spine boards are not indicated, only for patient movements. One thing. Okay. So immobilization doesn't mean hard surfaces. You should keep the patient immobile on a normal alphabet is good enough. So immobilization we are done. What else? What else can you do to prevent secondary spinal injuries? Hypoxia. Already a spinal cord injury is there causing cellular destruction. So if patient is hypoxic, hypoxia should be treated with oxygen adjuvant so that hypoxia will not cause cellular destruction of the affected area. So hypoxia should be treated, hyperoxia should be prevented. So unnecessary oxygen should not be given, and prevent hypoglycemia and prevent hyperglycemia. Hyperglycemia as such will not cause secondary wound injury but will cause sepsis. So hyperglycemia should be treated and hypoglycemia should be prevented. And most importantly,
Normothermia.
In traumatic brain injury, for spinal injury, it is blood pressure. So your perfusion pressure should be kept above 75 millimeter of mercury. So cutoff value of more than 75 is only told. What is the actual cutoff value required is not properly studied as such. So if hypotension is there, either IV fluid boluses or vasoactive agent should be given to maintain a mean arterial pressure more than 75 millimeter of mercury. So that much should be done to prevent secondary spinal cord injuries. That is one thing. What are the other supportive treatment you will give? Pain management you will give.
Pain management.
When you give pain management, what are the important things you will note? This patient has pain. Patient is complaining of severe pain. What are the important things you will keep in mind when you give analgesics? This patient complains of pain. What is analgesic you will give?
Initially, we'll start on paracetamol.
Okay, you start on paracetamol. Patient's pain score is what, 8 out of 10, right? Paracetamol is enough for a C4, C3, C4, C5, C6 spinal fracture patient with...
Then you can start on NSAID after.
You can start on NSAIDs.
Creatinine, if it's normal, we can start on NSAIDs.
Okay.
And if after
What did
CT
you give
brain,
for this patient?
paracetamol.
Paracetamol and NSAID is the analgesics you gave for this patient?
Initially, then after CT brain ruling out any IC bleed, we are given tramadol also.
Tramadol. You are given tramadol. Okay. What else? Anything else other than
Opioid analgesics. You can
opioids? You give opioids.
Yeah,
This is a patient who requires opioids.
Opioids.
What will you look when you give opioid analgesics in this patient?
Respiratory depression.
Respiratory depression. Because this patient already has a C5 injury, so patient may have phrenic nerve involvement. Even if phrenic nerve involvement is not there, what other involvement does this patient definitely has that will impair his respiration? C5 phrenic nerve, we are not finding any PCO2 retention. He is maintaining respiratory rate. His respiratory rate is normal, saturation normal, everything is normal, right? So right now there is nothing for us to suspect phrenic nerve injury. But even though phrenic nerve is normal, I would say this patient doesn't have a normal respiration. Why? What other neurological or what other muscular thing is affected?
respirations also with paralysis.
Other muscles of respiration, the intercostal muscles are all gone. So the patient doesn't have intercostal muscle usage. Patient, if at all using, is only using diaphragm. Okay. So patients can develop what and all? What other respiratory complications this patient can develop?
Pneumonia,
Due to?
not proper ventilation.
There is only diaphragmatic movement. That too may not be adequate. Accessory means intercostal muscles are all gone. Why can this patient develop pneumonia? What is aspiration? What is aspiration? But that is very obvious one. Collapse. Atelectasis. Atelectasis. So since patient doesn't have any forced way to inspire, there are lung areas which is dependent, gravity dependent lung areas will collapse. So atelectasis, and atelectasis can develop pneumonia. So that is one thing. So this patient's tidal volume can progressively come down. Patient's saturation can progressively come down. So when you give opioid to this patient, you should be extremely careful. You can give, it's not like it is not indicated, but IV opioid should be very clearly monitored. Okay. So that is one pulmonary condition you should suspect. What else? What other complications and what other supportive management will you give?
And then prophylactic antibiotic.
Prophylactic antibiotics for preventing infections. That's fine. For spinal
Tetanus, DVT prophylaxis.
DVT. This patient is going to be quadriplegic. This patient within next 72 hours has increased risk, more than 60% risk to develop DVTs. So DVT prophylaxis need to be initiated. So CT brain to rule out hemorrhages, repeat fast to rule out, make sure that there is no HB loss or intra-abdominal fluids. If no hemorrhagic is seen, you should start on early anticoagulation for patient, DVT prophylaxis by stockings, and frequent movements. Every second hour, frequent movements should be manually done to prevent DVT. Okay, so DVT prophylaxis. What else? This patient's spinal cord injury, right? Including motor fibers, sensory fibers. What other fibers are disrupted? Autonomic. So autonomic nervous system controls bowel and bladder movements. So bladder, you have done a Foley's catheterization, so bladder is taken care. Bowel movements. So patient will go into paresis. Dilated bowels, not passing stools, and that causing vomiting is the possibility here. So Ryle's tube insertion, Ryle's tube decompression of abdomen is important. Flattest tube insertion, flattest tube decompression of intestines are important. And fluid diet to be initiated, and solely by assessing the bowel movements of the patient. That should be taken care. Okay. What are the other complications you might see in this patient over the next course of days? Bed sore production. So, oxygen therapy for affected bed sores can be given. What else? What else? If this patient suddenly develops severe hypertension, heart BP of 170 over 100 with bradycardia, what will you suspect? Transient episodes. Patient develops bradycardia, patient develops severe hypertension, 170, 180 systolic BPs. But patient has bradycardia. Intermittent episodes. After like 2 minutes, 5 minutes, it resolves by itself.
I see.
Autonomic dystonia. Yes. This patient's autonomic dysfunction can cause severe changes, transient changes in hypertension, causing severe hypertension, bradycardia. Easiest way to identify is that patient will have sweating. Associated, the area in which it is associated will only have sweating. So usually below the spinal injury level there won't be any sweating as such, but associated with this, and pupillary constriction and dilation will change according to the autonomic system that is activated. Okay. So autonomic dystonia is one thing you need to look into, and as we told earlier, neurogenic shock need to be looked into. Neurogenic shock need not be present on the first day or second day. It can develop any time within a week's time. So up to 1 to 2 weeks, neurogenic shock can develop. Okay. Now, you have already done MRI, you are diagnosed the lesion is at C5, C6 level. You continue to monitor this patient. You continue to take ABG, PCO2 levels. First day, there is no problem at all. Till when will you expect the patient to develop phrenic nerve injury? Or can this patient develop phrenic nerve injury? Now you have diagnosed the lesion. Lesion is at C6. PCO2 levels over last 12 hours is normal. Is it possible for this patient to develop phrenic nerve injury?
Yes, you have to stabilize with surgery. Post surgery only we can stop the. Because if there is any mobilization of the spine, there can be chance of.
But you have maintained it's an ideal environment. You are keeping the patient completely immobile. You are keeping the spine normal. You are given steroids, all these things. Is there any possibility of developing phrenic nerve injury? Or think that this patient sustains spinal injury at the level of T1. Will he develop phrenic nerve injury? T1 and higher, T1, C7, C6, up to there. So basically, phrenic nerve injury may not be a direct cause of spinal injury. It can be due to compression due to edema. So if a patient has a lower spinal injury, like C7 or T1 injury also, the paraspinal edema can ascend up, causing C5 injury, C5 compression, not injury as such, C5 spinal compression causing phrenic nerve injury. So any traumatic spinal cord patient can develop phrenic nerve injury over 48 hours if the injury is above the level of T1 because of ascending spinal edema. More than 60% of cervical spinal cord injury patients will require intubation within 48 hours. This patient required intubation.
Oh, yes.
At what time?
After one day, he had progressively desaturated. He had tachypneas are developing. He was in respiratory distress. He was intubated.
So this can be one of the mechanisms for that. It may not be the same. It can be due to the spinal injury itself, but it can be progression of spinal edema as such. Okay, so when you intubate, what are the things you will make sure, or what are the things you will look into when you are intubating this patient?
Once we remove the cervical collar, we have to make sure we give a cervical inline stabilization.
Inline stabilization.
And
So
only
intubation can be only done with inline stabilization.
Chin lift, head tilt should be avoided. Only jaw thrust can be given.
Okay. How do you ideally intubate this patient?
With the help of fiber optic.
This patient is a classical case for delayed sequence intubation. You have adequate time to identify why the patient requires intubation and whether this patient requires intubation. So, a awake intubation or a fiber optic bronchoscopy assisted intubation is the ideal intubating technique for him rather than rapid sequence intubation. Okay. If you give rapid sequence intubation, what is the drugs that you will prefer? Especially within 6 hours of trauma.
Ketamine
can be given once traumatic brain injury is ruled out. If ketamine, will you give etomidate? Is etomidate contraindicated?
Because initial
transient hypotension.
Etomidate can cause hypocortisolism, means cortical suppression. Post-trauma patients, most probably they will be on adrenal. The body will be in adrenal rush. So cortical suppression can bring out a hidden hypotension. Patient may not show features of hypotension, but once you use etomidate, it can bring out features of shock. So it's not like contraindicated, but post-etomidate, patient goes to shock, you should look for other features of hemorrhage. Okay. Anything else?
Then we can, for imaging, we can use criteria and access criteria. Canadian C-spine.
That is not for this patient.
Not for this patient. Generally.
What type of patients will you use decision-making criteria? What are those decision-making criteria? You got two, right? Nexus criteria and Canadian C-spine. What is Nexus criteria?
Nexus criteria will check for...
What is Nexus?
Nexus, National Emergency X radiography.
X-ray utilization study. Nexus criteria. What are those studies for? Whom are those studies for? What type of patients?
With full GCS.
Low risk for spinal injury. You don't do it for a high risk spinal injury patient. So who are high risk spinal injury patients?
With dangerous mechanism.
What is dangerous mechanism?
Dangerous mechanism, it can be fall from a height of around 3 feet or stairs, 5 stairs, or high speed motor vehicle collision more than 100 kilometers.
No, that is for
Say-
Canadian C-spine
Canadian.
injury. Normally, high-speed motor vehicle accident is
truck or bus.
30 miles per hour. That is around 56 kilometer per hour. More than 56 kilometer per hour is dangerous mechanism.
Then
In
ejection-
Canadian C-spine rule is the high-risk criteria of 100 kilometer per hour. But actual high-risk criteria for spinal injury is 56 kilometer per hour is motor vehicle accident of 56 km per hour or motor vehicle accident
Violent collision with a truck or bus.
Immobile cycle or motor vehicle accident with an immobile object, exactly like him. And
Loss of consciousness.
any neurological deficit as such,
Any other
paresthesias,
distraction
neurological
injury.
deficits, then
Any other distraction? injury?
no, that is for NETSUS criteria. We are talking about high risk criteria.
Cycle
Age more than 65.
65 years.
Known case of osteoporosis, cancer, rheumatoid arthritis, cervical spondylosis, all these are high risk. Can a cervical spondylosis patient develop spinal injury with minimal trauma?
Yes.
What is the mechanism?
Or hyperextension flexion.
Since cervical spondylosis, spinal cord is very rigid, so a acute hyperextension injury can produce symptoms similar to central cord syndrome. Acute central cord syndrome. How is central cord syndrome presenting?
Central cord syndrome, there will be weakness more in the upper than the lower limb.
Yes. Patient will have bilateral upper limb and lower limb weakness, but upper limb weakness will be much more than lower limb weakness, and most probably bladder will be spared. Okay. Varying degrees of sensory deficits will be there. Okay. So, acute cervical spondylosis patient can develop like central cord syndrome kind of spinal injury. So, high risk patients. So, NETSUS criteria, patient with low risk of spinal injury should fulfill all 5 criteria of NETSUS to avoid X-ray utilization. That is, you don't have to take a CT or X-ray, C-spine, AP or lateral. So, what are the NETSUS criteria?
And it's posterior midline spinal
Absence.
tenderness.
Absence of posterior. We are not looking for absence of posterior midline spinal tenderness.
Then any painful distraction injury.
There should not be any painful. What
distraction.
are painful distraction injuries?
Other open
Long bone fractures,
long bone fractures,
lacerations, lacerations, degloving injuries, crush injuries, second degree or higher burns, facial injuries. Distracting injury should not be there then.
Intoxication should not be
No full alertness. Alertness, no evidence of intoxication. One more.
Mechanism of injury.
NETSUS doesn't have mechanism of injury.
And focal neurologic deficit should not be there.
No focal neurological deficits. Okay, that's NETSUS. Both NETSUS criteria as well as Canadian C-spine rule are extensively studied and vetted. Sensitivity of around 99.4%. Specificity is pretty low, 48 to 50% only, but we are looking for sensitivity. So you can use either one. Difference is in NETSUS criteria, there is no high risk patients given. You need to know high risk patients to apply NETSUS criteria. But if you take Canadian C-spine injury, the criteria starts with
high risk.
Do not follow if patient's age is more than 65. That is the first thing. So even if you don't know high risk, the high risk is always included in Canadian C-spine rule. So you have to rule all high risk, then intermediate risk, and then only low risk will come. So it's unlikely that you will miss a high risk patient if you apply Canadian C-spine rule rather than NETSUS. But the efficacy of rule is both same. Anything else? That's it, right? Okay.